Hello everyone. My name is Pat Huckabee and I'm the Senior Ambassador at Monarch Healthcare. Monarch Healthcare is a large group of doctors, about 2,500, who contract and partner with your HMO plans. We are the physicians that take care of you, most of the physicians that take care of you in your day-to-day medical treatment. As Senior Ambassador, you can think of me as a go-between between you and your physician, helping you to navigate any special situations you may encounter. For instance, you may get an authorization to see a specialist, but when you call for an appointment, you can't see the doctor as soon as you would like. So then you could call me and I could see if we have someone else that could possibly see you sooner. Today, we're going to be talking about a very important topic, reducing the risk of colon cancer. And we're very fortunate to have as our guest Dr. Ketan Shah, and he's a gastroenterologist with the Saddleback Medical Group practice here in Laguna Hills, and he's also a Monarch doctor. So those of you that are with Monarch could get a referral to Dr. Shah. And so it's nice to have a doctor that you can meet on our show today, because all of us at one time or another, I think, are going to be able to be visiting a gastroenterologist,
Yeah,
right? Yeah.
For one reason or another.
For one reason or another, yeah. So let's start out by maybe you could give us a little background. You're relatively new to Monarch and in the group, in the Saddleback group.
I am. Thanks for having me, Pat.
Yes.
My name is Ketan Shah, and I was born and raised in the LA area, so I'm a native of Southern California. Completed my undergraduate studies at UCLA, completed my medical degree and Master's of Business Administration at USC. Then my residency in North Carolina, made the trek out to the East Coast for 4 years and completed my residency in both internal medicine and pediatrics, and finalized my training at UC Irvine in adult gastroenterology and graduated pretty recently, last year in 2015.
Yeah.
I joined the Saddleback Medical Group in August of 2015, and it's my pleasure and honor to be here and serve this community.
Wow. Did you, because you were in so many different areas, like of medicine and business, were you kind of making up your mind, or did you kind of just exploring? Or
I was, and I wanted to keep as many doors open as possible, and I thought that administration, a training in administration would be helpful at any point in my career.
That's true, yeah, because we have some doctors now running Monarch that are that have taken that same route, with private practice and then changing later on. Yeah, it's very interesting, the options that are open to us today.
It is. There are lots of them.
Yeah, right. So, well, we're happy to have you here in your capacity now.
Thank you.
And I'm sure we need these doctors, all of us, because, like I said, at one time or another, all of us are going to see you.
Right.
Someone like you, in your specialty. Yeah. So, let's start out. Give us some background about colon cancer. The topic is reducing the risk, and we are going to emphasize that, but give us some background.
Sure. So we'll be talking about colorectal cancer today. Colorectal cancer is very common. About 1 in 20 people get it. It occurs in about 5% of people. It's the 4th leading cause of cancer in this country, and the 2nd leading cause of cancer deaths in this country. It becomes more common as people get older, as with most cancers. Yeah. And the average age of diagnosis is about 72. That being said, younger people are being affected with colon cancer at increasing rates, and about 15% of patients with colon cancer are younger than the age of 50. The recent study actually showed that the rates are rising in younger people, and by 2030, the rates are approximately going to double in patients who are less than 50. We're doing a great job with preventing colon cancer and decreasing incidence in patients who are over 50, but young patients are being affected more and more. The risk factors for colon cancer are multiple. There are what we call modifiable and non-modifiable risk factors. Modifiable meaning things we can do something about, non-modifiable meaning things we were born with and can't do anything about. So for example, patients who are of male gender are at slightly higher risk of colorectal cancer. Those who are African American in ethnicity and those who are older in age are at higher risk of getting colon cancer. Additionally, things we can't do anything about are our family. Those who have a family history of colorectal cancer or advanced polyps or certain genetic syndromes like polyposis syndromes are at higher risk for colon cancer. And additionally, patients with certain medical conditions like inflammatory bowel disease like Crohn's disease or ulcerative colitis, Lynch syndrome, and especially patients who themselves have had a history of polyps are at higher risk of getting colorectal cancer. Things we can do something about, there are actually lots of things that we do as lifestyle choices that increase the risk of colorectal cancer. For example, obesity is a major risk.
Right.
Insufficient physical activity is also a risk factor, and certain dietary and other lifestyle choices like excessive consumption of red meat or processed meat, insufficient consumption of fruits or vegetables, fiber are risk factors. And finally, excessive consumption of alcohol and smoking are risk factors for colorectal cancer.
Yeah. So that's kind of an overview, and we're going to kind of go back to that. We have a few slides and get into more detail about it. But yeah, that was very surprising though about younger people. Has anybody discovered the reason for that?
Well, we think we see a lot of what we're calling adult onset diseases affecting our youth, including obesity, but particularly diabetes, high blood pressure, high cholesterol.
Really?
And we think that a lot of lifestyle choices have to do with the increased incidence of those disorders in the youth, and those lifestyle choices happen to also increase the risk of getting colon cancer in young people. So yeah, so it's lifestyle. Yeah, it is.
A lot of times. Well, it goes back to that. It's how are the choices that we make along the way.
It really does. That's a huge part of it.
Yeah, and so let's see. Let's go into symptoms now, and we do have a slide for that. So that's a pretty long list there. So we want to cover that.
So this list isn't meant to scare anybody, and certainly not everybody or even a majority of people who have these symptoms has colon cancer, but this list of symptoms is meant to just make people aware of what patients with colon cancer what type of symptoms these patients may present with. So bleeding is the most common symptom, which could include like rectal bleeding or blood in the stools or even dark or black stools. And sometimes bleeding could be in a very microscopic amount that's reflected only on blood tests with the blood count, and patients can be anemic, and that could be the only presenting symptoms. Patients could also have things like a change in their bowel habits, like a change in the frequency, consistency, caliber, or urgency of their bowel movements. They could present with pain, or they could present with unexpected weight loss. The problem with symptoms, however, is that most patients who have symptoms and have colorectal cancer are diagnosed with late-stage colon cancer. And those who are diagnosed at an earlier stage of colorectal cancer, most of those patients don't have any symptoms. And there's a huge survival difference between patients who are diagnosed at an early stage versus those who are diagnosed at a late stage. Those who are diagnosed at an early stage, who are usually picked up during routine screening colonoscopies, have a great survival. They have an over 90% survival in 5 years. But those who are diagnosed at a late stage, which happens to be over 50% of patients diagnosed with colon cancer that are diagnosed at a late stage, those patients have an only less than 15% survival at 5 years. And those are usually the patients who have had symptoms and sometimes waited too long and didn't abide by the recommended screening guidelines.
That's what we were just talking about, that because it's that thing about, you know, having some kind of symptom but saying, oh, that's nothing, you know, and waiting, or like you say, we all have the ability now with our insurance. That's the one thing the Affordable Care Act gave us. Well, our insurance has given it all along, is to get these preventative screenings. And it's only up to us to make the appointment and take the opportunity, right? Yeah, so everybody listen and learn again, right? That 90%, that's a good survival rate, right?
It is a great survival rate when it's diagnosed at an early stage.
Yeah, that's I remember when Katie Couric, her husband died of it several years ago. There was a lot in the newspaper at the time, you know. And then I think everybody has a heightened awareness of, oh, you better go get that screening, because she was relatively young, I think.
Correct.
Yeah, when he died. And then we get, we get all alerted again, and then it kind of fades away for a while. Yeah.
It's important to be aware of these types of things, absolutely.
Right, and of course the chances, if you do it, that you got such a much better survival rate. Yeah. So the next one would be reducing the risk. That's really our topic today, and that's our slide. We want to look at that, so let's go over that.
Well, we're going to talk about preventing colon cancer, but also screening, and we should first talk about what the difference between screening and prevention is. So screening for a disease means detecting it, hopefully at an early stage, but after it has already developed. For example, using mammograms to screen for breast cancer after it has developed, using PSAs or rectal exams to screen for prostate cancer after it has developed. We can screen for colon cancer after it has developed with multiple tests, but the difference between most of these other conditions and colon cancer is that we can actually take certain steps to not only screen for it and find it early, but also prevent it before it has ever even developed.
Yeah.
So the ways to screen for colon cancer, there are multiple tests, including like stool tests. There is even a new stool test called the stool DNA test, which has more sensitivity and accuracy. There's a CAT scan called a CT colonography or virtual colonoscopy. But colonoscopy itself is a test that can be used to both screen for and prevent colon cancer. And colonoscopy is the only way to truly prevent colon cancer. And we'll talk about that in great deal. What can we do to reduce the risk, though? There are multiple lifestyle modifications we can make. We can try to maintain a healthy weight and lose excess weight. We can try to maximize our physical activity, and we can improve lifestyle choices, such as minimizing our consumption of red meat and processed meat.
I wanted to ask you about that. Why? How does the meat affect?
Yeah, I think the enzymes in the meat and the protein in the meat somehow has some chemical reaction in with the colon cells, thus increasing the carcinogenic effects that it has. It has a very carcinogenic effect.
Yeah, if you're a very excessive meat eater, in other words. It wouldn't be like maybe an average, but the excessive.
Exactly.
Yeah, so we're talking about excessive here, not just an average. Or even
it's
reducing.
Really, exactly. And what I'm talking about is ways to reduce the risk. So reducing the amount or minimizing the amount of red meat or processed meat has certainly been proven to help. Also maximizing things like fruits, vegetables, foods that are high in fiber such as whole grains, whole wheat, and also foods that are high in calcium and folate have been proven to reduce the risk of getting colon cancer. Some studies have shown that aspirin reduces the risk of colon cancer.
Just like heart circulation.
Exactly. But really truly the only way to almost 100% prevent colon cancer is with colonoscopy. And the reason is that 100% every single colon cancer starts off as a polyp. And a polyp is a benign but precancerous growth in the colon that can be fairly easily detected during colonoscopy and removed. And the removal of these precancerous polyps has been proven to reduce the risk of getting colon cancer by about 90% to almost 100%, and also reduce the risk of getting late stage or advanced stage disease by about 70%, reduce the risk of dying from colon cancer by about 50%. And so it's a very effective exam to prevent colon cancer from occurring.
Right, yeah. Well, that's great to hear. I mean, we want to hear something positive here, and this is what it is. This is the good news.
Yes.
How did these things form? these polyps? How do they
So
form?
polyps are genetic, but they have
Yeah.
the same risk factors as colorectal cancer. They're the precursors to cancer. And so it's mainly genetics, but also all of the lifestyle risk factors that I mentioned are the same risk factors for polyps as they are for cancer.
We were talking about just before the show about the seeds, and you were saying a lot of times. Tell what we were talking about,
Yes,
because
of course.
yeah, this is something where it's these two diseases or these occurrences are easy to get confused.
Yeah,
right?
absolutely.
Okay.
So you asked me about seeds,
Yeah.
which is a great question,
Yeah.
and that question mainly pertains to a different condition called diverticulosis,
Yeah.
which is also a common
And
condition
nuts
of the
and
colon.
things like that.
And previously we were recommending that people avoid seeds, nuts,
Yeah.
and popcorn for diverticulosis,
Yeah.
and we no longer recommend that.
Yeah.
Recent studies have shown that that's not been helpful at improving diverticular disease. But
Even
again, a
after-
different condition than colon cancer.
Yeah, so that's we have to keep those two separate in our minds as we're talking here. And like we said, we have to have you back to talk about that.
I would love to.
Because that's another thing that you know, we experience as we get older.
It would be my pleasure.
Yeah. So yeah, and then that calcium and the tobacco. So in other words, when I look at reducing the risk here, it's all the stuff that you would mention for diabetes,
Exactly.
for so many other
A lot of the risk
conditions, right?
factors are the same.
It's the same.
They are.
Yeah,
They are.
we do the same healthy things.
Well, let
you
me
know.
talk to you more about
Yeah.
colonoscopy,
Right.
since it is what I do,
Sure.
and so I know a lot of people have a lot of questions
Oh,
about
yeah.
the exam. And so the colon itself, it's an organ that's the last 5 feet of the 25 feet that our digestive system consists of.
Yeah.
And it starts off at the end of the small intestine on the right lower part of the abdomen, as we see on the slide on the screen. And it's shaped in an upside down U shape and ends up in the rectum. And so it's an organ that's about 5 feet long, and during colonoscopy we examine this organ by inserting a long flexible tube called a colonoscope. It's very, very flexible and has a camera and a light at the end of it, and it's inserted into the rectum and advanced all the way about 5 feet inside to the beginning of the colon on the right side. And then the colon is examined as the scope is withdrawn, and during that examination, during the careful examination, we look for polyps, which, as I mentioned too, are those benign but precancerous growths, and we remove them along the way. The exam takes about half an hour, and it does involve a prep process, which most people have
that's what I was
questions
curious
about.
about.
And it obviously is what people say is the least fun part of the exam, but it's improved quite a bit. The prep used to consist of a full gallon of pretty awful tasting stuff called Go Lightly or Fleet's phosphosoda, but a lot of the newer preps are much more palatable and, more importantly, lower in volume. So some of the preps are as low as 5 or 16 ounces per dose, split into 2 doses, one taken the night before, the other taken the morning of the exam. Each dose does need to be followed by some clear liquid like water, but that's what people say is much better than the previous preps, that full gallon.
Yeah, that full gallon.
Sedation for the exam. The exam is usually done with sedation, which are medicines given by IV to make patients sleepy and comfortable. Some patients who have more complex medical conditions need like an anesthesiologist to help with the sedation, but most patients are sedated. Then during the exam, if we can advance to the next slide, we look for polyps.
Okay.
And we remove polyps
Yeah.
as we see them. So let's talk about polyps. So polyps are benign but precancerous growths, and they can be as small as a couple of millimeters or as large as several centimeters. And every single colon cancer starts off as a polyp, and polyps are very, very common actually. About almost 50% of patients over the age of 50 have polyps, of which there are multiple kinds. There are some polyps that are not precancerous at all, and some polyps that are precancerous. The precancerous kinds are usually called adenomas.
Okay.
And
I was wondering what that word was.
Exactly. And the adenomas are of multiple types as well. The main 2 types are tubular adenomas and sessile serrated adenomas. The main differences between those polyps are in their appearance as well as their cancer risk. So like I said, all adenomas are precancer. It's not a matter of if, it's a matter of when they turn into colon cancer. And the tubular adenomas, the most common types of polyps, turn into cancer in about 5 to 10 years. But the sessile serrated adenomas are a polyp that we are becoming more and more aware of. They're flatter, they're more subtle, so they're more difficult to detect.
I was going to say, it looked like it was more difficult.
Right, exactly.
Yeah.
And they turn into cancer more quickly in only about 3 to 5 years.
Right.
So during colonoscopy, if we can go back actually to the last slide.
Let's go back to, there you go, we're still.
We remove polyps by multiple methods. One is we could take what's called a forceps and kind of pinch it off, but really the most effective way to remove polyps is what's shown on the screen. It was just called a snare. It's a wire loop that we, in a catheter, that we put down the scope, and we put the loop around the polyp, and we actually cut it. Sometimes we cut it just with the mechanics of the snare itself, and sometimes we use cautery. Sometimes when polyps are very, very large, we need to use more advanced techniques, which are called endoscopic mucosal resection, which I won't go into the details about, but the message I wanted to give about that is that in 2016, almost every single polyp, benign but precancerous polyp, can be removed during colonoscopy. It should be extremely rare, if never, should a patient be referred for surgery to remove a benign polyp.
So in other words, you wouldn't have to come back.
Well,
is that what you're saying?
no, you would have to come back, but surgery to remove a part of the colon is a big deal.
Oh, for that, but
For
just to
that.
remove the polyps.
Right, so
if you're
sometimes
seeing them, you're removing them.
Exactly. Sometimes there are larger polyps that need more advanced techniques, and some doctors specialize in those techniques. I was trained in some of those techniques as well. But it's kind of an older style now to refer patients to surgery, to have their part of their colon removed surgically for a polyp.
Oh, okay. That was an older technique.
That was an older technique.
I see.
So, like I said, during colonoscopy, we remove these polyps.
I was wondering, if you said, what is the average number? Do you have any idea in your mind? And how long would like, if a person didn't have too many polyps, they'd be through kind of quickly with that, But how long, have you ever had a real record for how many you had to remove?
Most people have 1 or 2, maybe a few polyps that we remove. But some patients are predisposed to having polyps, and some patients have 20, 50, 100.
How long are they there then?
Well, they've probably been there for a while, but they probably also have a genetic syndrome.
Yeah, but how long would it take for you to do that?
Oh, it could take a couple hours, but most colonoscopies take about half an hour to complete.
So the average would be about, but it could, every once in a while, it could take that long?
Every once in a while, it could take long for that reason or other technical reasons making colonoscopy a little more difficult. But it is a very effective exam. I was talking about the sedation. So because of sedation, most patients do need to recover for about half an hour after the procedure. But that brings me to the point of doing the exam unsedated, which is a newer concept with colonoscopy. More and more patients are choosing themselves to do the exam without sedation, because our techniques and our scopes have improved to make the exam actually relatively comfortable to even do awake. It's totally patient's preference to do so, but benefits of doing the exam awake are that patients are able to watch their exam, they're able to drive home from the exam if they have ride issues. They can drive that same day and go back to work or do whatever activities they were wanting to do. They don't have to go through the risks of getting sedation. And most people say that the discomfort is mild or minimal, doesn't last very long. And studies have shown that about 90% of patients who get the exam without sedation would be willing to do it again the same way. Most of my patients who I do without sedation say they would want to do it that same day, even that same way, even those who have had sedation before. So it's a newer way of doing colonoscopy. We have another, I think you've already talked about this a little bit. It wouldn't hurt to just go over it. Absolutely. So I think we were going to talk about the effectiveness of colonoscopy. Is it 100% effective? And the answer is no. Colonoscopy is not a perfect test. It's not 100% effective. About 9% of patients diagnosed with colon cancer have actually had a colonoscopy within 5 years. And why is that? Well, we think the reason that people are still getting cancer, it is a low percentage, but people are still getting cancer because polyps are likely being missed. Polyps can be missed for multiple reasons. One is that they could be hiding in between or behind the multiple folds of the colon.
How long that
Exactly.
that
Or
is.
the polyps can be very flat and subtle. And those flat and subtle polyps, like I was saying, these sessile serrated adenomatous polyps are the ones that are more difficult to detect and are the ones that turn into cancer more quickly, only 3 to 5 years. So we have been likely missing these polyps, and that's probably why people are still getting cancer. Polyps are also difficult, sometimes difficult to remove, and they sometimes are incompletely removed. And up to 30% of polyp studies have shown large polyps are incompletely removed despite a gastroenterologist's best effort. So we as gastroenterologists are advised by societies to keep track of what's called the adenoma detection rate, which is it's kind of like our batting average, how often we're finding polyps. Because those polyps are there, we just need to be looking hard enough for them. So benchmarks on a national level are that we should be finding polyps in about 25% of patients. The adenoma detection rate is like a batting average, how many exams we are finding precancerous polyps divided by the total number of first-time screening exams that we're doing. So that number should be at least 25%, but the highest performing gastroenterologists find polyps in about 50% of patients. Multiple studies have shown that. And so if 50% of patients have polyps, but on average they're found only about 25% of the time, we're probably missing at least half of polyps, and that's probably the reason why patients are still getting cancer despite having a colonoscopy. So with newer techniques, especially more thorough techniques, and just spending a little while longer examining the colon just by a few minutes, these techniques have been proven to increase our detection rates of precancerous polyps, and in doing so, we can strive to increase our detection rates and hopefully get closer and closer to completely preventing colon cancer from happening.
Boy, that would be great. Yeah. So I think that we're almost at the end here, so we got very, very little time. And so I think we're going to save the guidelines. I think if people want to call in.
Sure, no, absolutely. But basically, the message here is get screened. Get screened starting at the age of 50 or 45 in African Americans, and get screened sooner, starting at the age of 40 or 10 years younger than the person in your family who has had colon cancer. So family history, get started at 40 or 10 years younger than the family member, and in patients without family history of colon cancer or advanced polyps, get screened starting at age 50, either with colonoscopy or with some of these other tests like stool tests or CAT scans. And these are proven methods to reduce the risk of getting colon cancer. Colonoscopy is the only proven way to completely prevent colon cancer by removing precancerous polyps.
Great. Okay, I think we've got the message. That's good. So, well, thank you very much for coming by.
It's very much my pleasure.
Answered a lot of questions, I think.
Well, thank you.
Then,
my contact info, I think, is on the next slide. If anyone is interested in seeing me, I would be more than happy to see anybody in the community.
Right. I think what we need to do is we need to remind everybody that they can get a referral through you.
Absolutely.
And so we want to be sure that they know that. And I want to remind everyone to join me at the Florence Sylvester Senior Center. I'm there the first Tuesday of every month from 10 to 11. And you can call either myself or customer service if you have any questions about today's show or anything else. And of course, if we've left anything out and you want to get in touch with Dr. Shaw, you can call me as well. So my number is always there. So anyway, thank you again.
Thank you for having me. It was my pleasure.
Taking this time with us.
Thank you, Pat.
And thank you for joining Senior Focus.